And thank you so much, Gaetano, and thank you so much, Kelsey, Wash Canada crew, for inviting me. It's a huge pleasure and an honor to be here, of course. Let me just go ahead and share my screen. Give me a thumbs up when you can see it, yeah? Is that good? Right
Looks
on.
good.
Perfect. Okay, so I'm really excited to be here because I want to tell you about some of the work we've been doing here at the Dava Institute for Global Health Research at York University on public health engineering in humanitarian crises. And we've just started this process of formalizing what we're calling the Humanitarian Water Lab. So I'm really, really happy to have this chance to talk about what the new organization, the new lab that's emerging. So I'm going to tell you some stories about problems and challenges I've seen in the field, the research that's come out of it, and how the lab is sort of emerging organically from this dialogue with the humanitarian sector. So before I get into it, at any time, if you have questions, please feel free to drop them in the chat. And then we can either take them as we go, or we can handle them at the end, yeah? Okay. So let me start this story by telling you off what set us off on this path, right? This here is an image of a hepatitis C isolation ward at the Médecins Sans Frontières, MSF, field hospital in the Jamam refugee camp in South Sudan. In 2013, I was there working as a water and sanitation specialist with MSF right after I finished my PhD with Ed at Guelph. And I was working in refugee camps that were really overwhelmed and underserviced and faced many outbreaks of waterborne disease. There was huge outbreaks of acute watery diarrhea. There was a risk of cholera, and there was an outbreak of hepatitis E. Now, hepatitis E is a waterborne disease. It's a vicious disease for which there's no cure, and all we can do medically is offer supportive care. It also has a very unusual pattern of attack. It primarily affects younger men and women in the 20s and 30s. And in the general population, it has a crude fatality rate, a CFR, of around 2%. However, for some unknown reason, for pregnant women who are in their second or third trimester, that CFR jumps to 20 or 25% for reasons that aren't understood. So you can imagine how difficult this was for the MSF staff, not being able to treat and help a lot of folks who came in once they were infected by hepatitis C. This really hardened our resolve to beat back the outbreak by preventing its spread in the community. And of course, to do this, we had to work on improving the water, sanitation, and hygiene, the wash services in the camp. That meant expanding sanitation coverage throughout the camps, building out our hand washing infrastructure, and scaling up hygiene promotion activities. Another important part, of course, was improving the safe water supply in the camp. Now, to do this, in the humanitarian sector, we really rely on chlorination. It's the most widely used method of water treatment. It's well suited to humanitarian contexts because it can provide lasting protection against recontamination. Now, humanitarian responders are guided by core standards on chlorination in the SPHERE handbook, in the MSF Public Health Engineering Manual, the OXAM and UNHCR water treatment guidelines. All of these guidelines generally say the same thing, that free residual chlorine, or FRC for short, at water distribution points should be between 0.2 and 0.5 milligrams per liter under normal conditions, or increase to 0.5 to 1 milligram per liter during outbreaks or when pH or turbidity are elevated. Now, what's interesting is that these are intended as universal targets that are applicable in any emergency setting around the world. Now, in humanitarian settings, our usual practice is to dose chlorine at the storage or water production point and then monitor that that designated guideline level is achieved at the water distribution points, also known as tap stands. So it's a very process-oriented model. But monitoring just at the distribution points misses what really matters for public health outcomes. What is the water quality where people are actually drinking it, right? In a refugee or an IDP camp, people have to collect water from these public distribution points. They carry it back to their shelters, and then they store and use that water over many hours. So the real question is, how safe is that water where people are actually consuming it? Now, in South Sudan, we worked really, really hard to achieve these core humanitarian guidelines, and we were able to at the point of distribution. But when we went to people's shelters to actually test the water they were consuming, very often we found it had no residual protection. In fact, because of the hepatitis E outbreak in the camps, the CDC had come in and they conducted systematic surveys that showed that between 40 and 58% of households that were ostensibly collecting water from chlorinated source had no detectable FRC protection in the water. A group from the University of Barcelona, a group of virologists came in, and they discovered human adenovirus in the stored household water, which is an indicator of human fecal contamination. So we saw two things. The water was unprotected by FRC, and it was being fecally contaminated in the home all during the midst of a major waterborne disease outbreak, despite meeting our core public health engineering guidelines and being safe at the tap stands. Now, you can imagine this was incredibly frustrating and deeply concerning for us in the field in the midst of this outbreak. So we started to do some digging on where these humanitarian chlorination guidelines came from. We discovered that these FRC standards aren't based on any field evidence from humanitarian settings. Instead, they're based on conventions from the WHO guidelines for drinking water quality, which means they come from and are meant for municipal pipe water systems. And of course, in a city like in Toronto or in Victoria or Manila or Tokyo, we drink water right from the tap. So that period after distribution isn't super important. However, in a refugee and IDP camp, people have to go through this entire journey of water that can be for 24 hours in a very unhygienic environment. So there are plenty of opportunities for recontamination to occur. So no wonder these guidelines aren't working in the radically different context of a refugee camp. This raised a question for us, of course. What was happening to that chlorine protection, that essential chlorine protection in the water supply after distribution? In response to this, in South Sudan, we launched studies in 3 refugee camps to investigate how water quality changed after distribution and whether or not those humanitarian guidelines could actually work to preserve water safety at the point of consumption. We discovered that even if we meet those humanitarian FRC standards at the distribution point, chlorine decay after distribution is very significant and very rapid. In South Sudan camps, we found that even delivering the upper range of the guideline limit meant we'd only have protection for about 10 hours, after which the water was vulnerable to being recontaminated by waterborne pathogens. As we start to look into it, we found, in fact, there are many, many reports of water being recontaminated after distribution, leading to the spread of waterborne illnesses amongst displaced populations. It's that period after distribution that matters most for public health. So the problem that we were seeing in South Sudan appeared to be very widespread throughout the humanitarian world. Now, we presented this data that we collected in South Sudan and our concerns about the humanitarian chlorination guidelines and water safety in refugee camps in a paper in the bulletin of the WHO. And what we came to realize is that if the existing guidelines don't reliably work, what we need urgently are evidence-based targets, chlorination targets, that can actually ensure safe water during that last mile of the safe water chain. That part that's really critical for protecting public health. Now, addressing this meant grappling with the phenomenon of post-distribution chlorine decay. Now, as you know, chlorine decay in municipal systems is pretty well understood, but there's very limited knowledge on what happens to water after the distribution network. In most municipal systems, that's not a concern as water is consumed directly from the tap. However, in refugee and IDP camps, and for that matter, any intermittent water system where people have to collect and store water over many hours, that post-distribution chlorine decay and what happens after the tap really matters for public health. No one had looked at this problem before. Seeing this problem in South Sudan, we were concerned, but we were wondering, is it a problem elsewhere? So we expanded to other refugee camps around the world, in Jordan, Rwanda, across multiple seasons, in collaboration with the UN Refugee Agency, UNHCR, and MSF. And we observed very similar problems as we had seen in South Sudan. Post-distribution chlorine decay was very rapid, in fact, and household water safety was very often compromised, especially in sites that were hot or had poor environmental conditions, which unfortunately is sort of emblematic of many refugee camps. The only sites in which the current guidelines actually worked were sites that had very, very high levels of wash services and cool winter seasons. So in the Azraq refugee camp during the winter, the standards work, but everywhere else they failed to work. Now, with these data, we started to experiment with ways to model post-distribution chlorine decay. And the first approach we took, of course, was looking at what is done in distribution systems and trying to adapt that approach by changing some of the assumptions. So we took the distribution system modeling approach and adapted it to the new post-distribution setting. But this presents unique modeling challenges because when you go from a distribution system, it's a closed system. When you go to after the tap, it's an open system. So there's a lot of variability that comes into play. To solve this modeling problem, we took a novel empirical modeling approach where we combined all the effects, combined all the decay driving factors into a combined effect driving decay after distribution. Now, our modeling based on these data from these refugee camps showed that context really matters for water safety. Post-distribution chlorine decay was very site-specific by nature and even changes over time at the same site. So a generalized FRC target, like that which exists in the SPHERE guidelines, all those central humanitarian handbooks, just isn't going to work, right? What we need are site-specific and seasonal FRC targets that can actually assure household water safety. Now, another approach that we start to take in recent years has been focusing on ensembles of artificial neural networks, a type of supervised machine learning. I see Mike is on the call. Mike is our graduate student who's been leading a lot of this work, and you see some of the papers that he's written from our group. Now, the ANN ensemble approach responds to a few limitations in the process-based modeling approach. One, as a data-driven approach, ANNs learn the underlying behavior from the data instead of assuming the behavior a priori, which is what we have to do in the process modeling approach. And in a situation like post-distribution chlorine decay, where the underlying phenomenon is not very well understood, this is a really powerful benefit. The other big benefit of taking this machine learning approach is that the process-based modeling approach generates a point prediction of what the household FRC will be, on which we base some recommendations on what you need to target at the tap stand. In contrast to ANN ensemble approach, we can better quantify that huge variability we see in situations and behaviors and decay driving factors after distribution, and we can combine the predictions of multiple ANNs into a probabilistic forecast. The other and third benefit of the ANN approach is that we're not limited to just chlorination data and time in the process-based approach. We can look at any kind of input signal, input data, and see if it has an effect on the outcome space we're interested in, which is the household chlorination. So we did some, Mike led this work on looking at what factors really matter, and we discovered that electrical conductivity and water temperature have an effect. So we've also built models that include those two factors in addition to the chlorination data. Now, we can use these ANN ensemble models to generate FRC targets that are based on the risk of not having sufficient FRC at the point of consumption. And this allows water system operators to specify the level of risk that they're comfortable with. It could be, we want to achieve 90% household water safety, and this is a target that will achieve it. Or, the chlorination is getting too high, we're running into like a taste odor problem, we have to lower it. So we accept a lower standard of water safety at the household. This is what the ANN ensemble approach enables us. Now, what's really important for us was translating this research into knowledge products and tools that can help improve public health engineering practice on the ground. Now, so with these modeling approaches that I just laid out, we start to analyze the data, and we generated a new suite of evidence-based guidance to replace that non-evidence-based universal targets in the current humanitarian guidelines. And these guidelines were specified for different field conditions, if it was hot, if it had poor wash conditions. And we took this to the humanitarian sector and we presented to them, and we got some pushback. This is great. This is guidelines that work in South Sudan, Jordan, Rwanda. But what about water supply systems in Nigeria or Bangladesh or Yemen? Will these work there? So this question of external validity came up, and that's a completely fair critique. What it made us realize is that we had built these really interesting algorithms and modeling approaches that we fed into data and generated, a suite of static targets. But if we put these models, these algorithms on the cloud, we could take advantage of the huge amount of water quality monitoring data that's collected every day in the humanitarian sector, mostly just for reporting purposes. So we put these analytics up on the web, and we built an open source web platform called the Safe Water Optimization Tool. The SWOT, or SWOT for short, the SWOT allows field workers anywhere in the world to take their local water quality monitoring data, upload it to our analytics, and process it using our numerical modeling and machine learning modeling tools, and generate a site-specific and evidence-based chlorination target that ensures household water safety for a particular user-specified duration of time. And we've made the SWOT freely available to humanitarian responders around the world. In 2019, we carried out a proof of concept study for the SWOT. Now, the objective of this evaluation was to assess if our tool, our prototype, could actually generate a site-specific and evidence-based water chlorination target using the water quality monitoring data in a real-world refugee camp settlement, and if that chlorination target thus generated could improve household water safety outcomes compared to the status quo FRC guidelines and sphere. Now, we carried out the study at the Kutupalamba Kali refugee settlement in Cox's Bazar in collaboration with MSF and the Bangladeshi NGO BRAC. Now, what we found was if the sphere target is delivered at tap stands, after 12 to 18 hours, which is the usual duration that people were storing water in their households, less than half of them had safe water at the point of consumption. However, if we implemented the SWOT target at the tap stands, when we followed up at households 12 to 18 hours later, we found that over 90% of households had safe water. So we effectively doubled the proportion of households having safe water at the point of consumption through the SWAT. So we're actually achieving the public health goal of delivering safe water at the point of consumption through the intervention of the SWAT and outperforming the existing guidelines quite substantially. Now we start to scale this tool up. It's already being used by 7 agencies around the world, and we're expanding the use cases for the SWAT. We're looking at medical facilities, at water trucking, at surface and groundwater sources, and demonstrating that the SWAT can work across the whole range of humanitarian water supply use cases. Now, as we were working on the SWAT of the past few years, we saw that this is just one question of many on WASH and emergencies. It was just published recently, ELRA, which is a UK-based funder for humanitarian research, commissioned the Humanitarian Health Evidence Review #2, following up on an initial report in 2013. In this HHER2, they found that they found 269 research studies published on humanitarian health topics between 2013 and 2021. Of these, only 21 were on WASH topics, about 4% of the total. And they very clearly stated that NCDs and WASH are the most neglected areas in humanitarian health. This is not much of a change. There's a bit more research than there was in the 2013, but this has been a consistent trend. So there's a huge need for research and innovation on WASH and emergencies. Just as we discovered this FRC problem, guideline problem in South Sudan, there are many evidence gaps in public health engineering practice. We keep doing things the way we're used to, despite seeing poor performance, because we don't have the means and resources in the humanitarian sector to solve those questions. So there are lots of opportunities to mobilize research and innovation to help improve public health engineering practice. Now, as we start to realize there were a lot of questions that were not being addressed, we went to some of our collaborators in the humanitarian sector, and we start to ask, what are some of the questions and challenges that you're struggling with? MSF told us about a problem they've been struggling with for about a decade when we first talked about it, about the interactions of chemical water quality and severe acute malnutrition amongst children during famines. In response to this question that was before, we mobilized a group of water engineers, pediatricians, and nutritionists to work together on looking at this problem and trying to generate some research and operational outputs that could help address it in the field. Now, during nutritional crises, otherwise known as famines, it's primarily children who are affected. And to treat malnutrition, kids need to be fed. So food is a kind of medicine in these situations. Most feeding programs in humanitarian settings are ambulatory. I mean, people come and get the food and take it home, and they undergo that treatment in their households over time. But the most critically ill patients are hospitalized in clinical settings, including in specialized facilities called ITFCs, or intensive therapeutic feeding centers. Now, SAM kids in these facilities receive treatment with therapeutic foods, milk powders like F75 and F100, solid high-calorie peanut butter-based rapid-to-use therapeutic foods. And in cases that are complicated by diarrhea or cholera, they may also take ORS or Resomol, which is ORS for SAM. The important thing is that these are all dry products, and they have to be reconstituted using locally available water supplies. In many of the places where we face food security issues, we also face water insecurity. And water availability is poor and often highly reliant on deep, highly mineralized groundwater sources in these arid settings. Now, why is that important? SAM kids are very, very sensitive to the electrolyte and mineral intakes they receive during treatment. That's why the composition of therapeutic milks, rehydration products, and other products using ITSCs are very carefully calibrated with respect to their electrolyte and mineral content. But these are dry products, and they have to be reconstituted using locally available water. And you see where the problem is coming in. In arid regions, the only source of water is these highly mineralized groundwater sources with very high levels of different electrolytes and minerals in that water. When this water is used to reconstitute these products, it throws off radically that careful calibration of electrolyte mineral intake that patients receive during the course of their treatment. And this can lead to really significant electrolyte and mineral imbalances, leading to physiological and metabolic disturbances in SAM kids and potentially life-threatening outcomes. This is something that MSF and other agencies responding to nutritional crises has seen, going back to nutritional crises in Somalia in 2007, in Ethiopia in 2017, and even recently now the emerging nutritional crisis in Horn of Africa today. What's interesting is that most of these products are manufactured and formulated in the global north, where the water available from the tap, say in France, is generally of pretty good quality. These products say nothing about what kind of water is required to prepare the product beyond just use good quality water. So at present, humanitarian responders have no guidance on what constitutes good quality water for this specific vulnerable subpopulation, or the scope of this problem, or how to manage it. So when presented with this problem, we initiated some research with MSF to synthesize the available knowledge on this topic. We looked at what is known already about electrolyte and mineral intakes and adverse outcomes for SAM kids through a systematic literature review and convening an expert panel. Through this process, we generated some provisional water quality guidance and management strategies for ITSCs. We identified knowledge gaps. There's actually very little research in this area. Our literature review turned up basically nothing on the allowable chemical water quality electrolyte mineral intake for SAM kids. So there's a huge knowledge gap here. And then we worked to elevate this issue amongst the humanitarian medical community through practitioner and academic conferences. So we generated through this process some operational guidance for MSF. We did about a dozen presentations to these different practitioner academic communities, and we have a few papers in the work now to get the word out there. Another concern that we've heard in our conversations from humanitarian responders, particularly during water supply, is around disinfection byproducts in treated water. And it's especially relevant in the early days of an emergency when direct chlorination of surface waters might be happening. That could be turbid and have high loads of natural organic material. We carried out the first study characterizing DBP levels in an emergency surface water intervention in Uganda. And we found there that the DBP levels following both rapid and conventional clarification did not exceed the WHO guidelines for DBPs for the general population, which is a huge relief. But concerns persisted about subchronic exposures at a lower level for specifically vulnerable subpopulations, especially pregnant women. And this is an area of work that Kitana's group is also leading on. By the way, we have some new data coming out of Uganda and Somaliland on the characterization levels and how the field methods that we use compared to gold standard lab methods. So we'll talk about that some more later, So through these conversations with practitioners and the problems that they face, organically, this idea of the Humanitarian Water Lab began to emerge. What we realized we were doing, and this is really what we want to build on, is we're acting as a bridge between the field and the university. What our goal is to work with practitioners and affected communities to understand the questions, right? What are the really pressing questions affecting public health in humanitarian field settings? We want to work with the researchers to mobilize the right kind of expertise to answer those specific pressing questions from the field. And then we want to work with the practitioners, researchers, and affected communities to translate that research into knowledge products and tools that can help us advance public health engineering practice in emergencies on the ground. Now at the lab, we do this kind of transdisciplinary research and knowledge translation, and we also aim to extend our impact through training and professional development activities, as well as convening international events. Now, I've told you a bit about the research we're doing, but we have three large streams. So modeling optimization of water supply for protecting public health in humanitarian LMIC settings, the interactions of chemical water quality and severe acute malnutrition. My light just turned off. And then infrastructural challenges for water supply and sanitation, resource-constrained urban and peri-urban settings. So looking at that transitional zone between humanitarian and development as well. These are the three areas that we're trying to focus on going forward. Now, what's really key to impact for us as well is communicating directly to practitioners and new engineers. And we do this through teaching and professional development opportunities. For the second year running now, we're running a new humanitarian water engineering course. So Eloisa is here with us, and Mike was on it previously. This helps us disseminate our research findings, develop new collaborations, train the next generation of humanitarian engineers, and enhance the skill sets of current practitioners. Much of WASH work is done by people based in low and middle income countries, in the host countries of refugee populations, and they often don't have many opportunities for formal training. So we really wanted to be able to serve them as well by helping, bring in the technical training that they need to elevate their capabilities in the field. We also aim to convene events and workshops. We did an emergency data science international workshop in 2018, from which a number of new projects emerged as practitioners share the challenges they're facing, connecting with researchers and designers and developers at this conference. We've also convened expert panels on the chemical water quality project and others. Our goal here is really to help set and articulate the humanitarian water research agenda, develop these networks, and learn about practitioner priorities, and then start doing the work of research translation and scaling. Now, the key to doing this work really is a network, right? And we really are keen to connect with people who are asking the same kind of questions. How can we advance public health engineering in emergencies and better protect people living through crises? We want to connect with research specialists in all areas of WASH, public health engineering, and with the practitioners to understand what their priorities are. So if you have questions, if you have ideas, we'd love to connect, and I'll share my contact at the end of this presentation. I also really want to invite you all to join us. So over the, we built that SWAT prototype in 2019, did a proof of concept in Bangladesh, and did a bunch of remote pilots, because really the primary use case for us is not us going to the field and collecting data, it's practitioners being able to collect the data, use the tool, and generate recommendations that they can actually implement and improve water safety outcomes. So we did a lot of implementations at UNHCR, NRC, Solidarity, and many different countries, and we learned a lot from our users. We learned a lot from those field experiences, and we've taken that learning and built out a version 2 of the SWAT. It's going from a prototype to a state-of-the-art web product. We're going to be launching it next week on Tuesday, November 8th, 11 a.m. It's a bit early PST. But please join us, and you can check it out at that link. We'd love to have you there and share more about what the version 2 brings and how it can help WASH practitioners and emergencies deliver safe water in those crisis settings. Yeah, and that's what I wanted to talk about. Thank you very much for your attention. If you want to learn more about the Humanitarian Water Lab, you can check out that link. If you want to learn more about the SWAT, check that link. We're on Twitter. And if you want to talk about anything, that's my email there. So, Keitana, I managed to do it. I managed to jam it into 30 minutes.